Great, thanks, Stephen, and thanks to our friends at ICOS for the opportunity to speak to you today about the role of cardiac imaging to characterize cardiac masses in patients with cancer. My name is Jeannie DeCara, and I'm the Director of Cardio-Oncology at University of Chicago. I have no disclosures for this talk. I will talk very briefly on the off-label use of ultrasound enhancing agents with high mechanical index imaging to evaluate perfusion. And my objectives over the next hour or so are to review the commonly used modalities to characterize masses. I'm going to focus primarily on tumors and less so on pseudotumors, with the exception of thrombi, which I think are relevant to patients with cancer. I'm going to be discussing some of the fundamental ways in which the various imaging modalities are unique or additive and where there are limitations. As an echocardiographer and not a multimodality imager, I'm going to be coming at this from the vantage point of an ordering provider and an end user, primarily because I think that the imaging reports have a lot of descriptive content in them. And I think if we have some foundational understanding of that content, we become more informed users of the imaging modalities, and we can extract more from the report to help our patients. I'm not going to be discussing the imaging fingerprint or profile of each and every type of tumor during this talk. And I think that's been covered really well in a variety of review articles. But for your convenience, I did include this citation here from JACC Cardio-Oncology, which is really good, and it covers that material very nicely. So cardiac tumors, broadly speaking, are broken into primary cardiac tumors and secondary cardiac tumors. Primary cardiac tumors are ones that arise within the heart and are exceedingly rare. The majority of those are benign, and about 50% of the tumors in that benign category are myxomas. Other tumors that are represented in that category include lipomas, papillary fibroelastomas, fibromas, hemangiomas. And then a smaller portion of primary cardiac tumors are malignant, and the sarcomas in this group are the most heavily represented. For secondary cardiac tumors, these are far, far more common than primary cardiac tumors, and the majority of these are metastases in patients with known primaries. With regard to secondary tumors, about 9% of patients who have metastasis have cardiac involvement at autopsy, and that number increases to about 14% in patients who have widely distant mets. Among the types of primary cancers, metastatic melanoma tends to really favor the heart. But the more common cancers that we see are breast and lung, leukemia, and lymphoma, and they are also well represented as cancers that will metastasize to the heart. Now, in real estate, the motto is location, 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 and I would say that that also applies to cardiac masses. We actually capitalize on the idea that certain masses or certain tumors have a propensity for certain places within the heart, whether it's the right side versus the left side. Some have favor the atria versus the ventricles, and then even the valves. And we really try to harness this information to narrow our differential diagnosis. And so if we have, we find a TE like this, where we see a large mass in the left atrium that's attached to the interatrial septum, we feel pretty comfortable putting left atrial myxoma at the top of that list in the differential diagnosis. Similarly, if we see a mobile tumor attached to a valve with a shimmering surface, we feel pretty confident that that is likely going to be a papillary fibroelastoma. And if we see a hyperrefractile and large mass in the myocardium, we start to think fibroma. But we often want more information than just the location from our imaging, right? So we want to understand the origin and the size of the tumor, and we want to understand its borders and its hemodynamic significance and its proximity to other cardiac structures. And we need that information because that helps us with surgical planning. Then after surgery or chemotherapy, we're using often the same imaging to do surveillance for recurrence or to assess the adequacy of our treatment. We have a wide array of techniques that we can use to image cardiac masses or cardiac tumors. I've listed echo in the middle because I think of a patient who is getting who's getting evaluated for a cardiac mass as kind of being on an imaging train, and I feel like echo is the first stop on that train. And so, and 2D echo in particular, right? That's where we always start. And I think that we can all appreciate the advantage of echo as a portable and widely accessible technique. And we depend on this technique to evaluate for underlying cardiovascular disease, including myocardial disease, as cardio-oncologists. But we can also harness the the color flow Doppler and spectral Doppler to understand a little bit more about the hemodynamic significance of a tumor and look for associated findings like wall motion abnormalities that might imply infiltration into the myocardium, or pericardial effusion, which would imply something more sinister happening. We also understand that echo is limited in patients with poor acoustic windows, and that we're left with 2D echo, at least mentally reconstructing a three-dimensional structure from a series of two-dimensional images, and sometimes we fall short. We understand that for vessels like the SVC, the IVC, and the pulmonary veins, echo can give us a pretty limited view of those vessels, and that can be limiting overall, because often that's the route by which tumors can infiltrate the heart. And we have a limited ability to evaluate perfusion and other tissue characteristics. That said, it's a pretty handy technique to start with, and I'm actually going to use myxomas over the next couple of slides to really demonstrate some of the old and some of the newer aspects of echo and how it can be helpful in differentiating a mass and its features. So this is an example here of a very large left atrial mass that's obviously prolapsing into the ventricle through the mitral valve, and you can see on color flow Doppler that there's some turbulence around that mass, and you can see on spectral Doppler that's associated with pseudo-mitral stenosis. Now, the point of attachment of this mass cannot be discerned by 2D transthoracic, but on 2D TE, we can see a nice attachment point to the intraatrial septum, and that we know that that's most likely going to be a myxoma, and in this case, the gross and histopathology were consistent with that. So that's 2D, but we live now in a 3D era, and so we have both 3D transthoracic as well as 3D TE. And those who use 3D imaging understand that we can image in several modes. We can image in a full volume mode, which, let's just take, for example, a mass that's in the ventricle. We can acquire the entire ventricle within a pyramid of data. We usually do that over the course of 2 to 6 beats to try to improve frame rate and image quality. We could use Live 3D, which is more of a pie-sliced shape of data, or we could use 3D Zoom. Now, 3D has advantages over 2D because once we acquire a 3D data set, we can, cut and crop into that data set to our heart's delight. And the patient doesn't have to still be there. So we can do that offline. Once the patient leaves, we can do it on our workstations. And studies have shown that 3D echo is superior to 2D for estimating the size of a cardiac mass. It's also helpful in discerning the shape and the texture of the mass and its site of attachment. It is still limited, just like 2D is, in its field of view. So again, SVC, IVC, and pulmonary veins can sometimes be, just a glimpse and not really the whole picture. This is an example of 2D and 3D TE in the same individual. So this is on the 2D TE, you can see that there's a mass in the left atrium attached to the intraatrial septum, and that the site of attachment on the 2D seems to be pretty broad-based. But you can see in the 3D image down here on the lower left that there is a stalk attached to this lesion, and that's really the site of attachment. And you can also appreciate that the texture, it seems to be very, very smooth, and that's in keeping with the gross pathology. And now with 3D, we also can introduce a light source into the 3D data set, and that's called transillumination, and we can really manipulate that light source to enhance some of the contours of a cardiac mass. And this is an example of that. In the upper left is a conventional 3D echo where you can see that there's a mass. It seems kind of globular, but when you apply this light source and you transilluminate the mass, you really can appreciate its polypoid appearance. And if you crop into that data set from above, looking down onto the left atrium in this bottom right image, you can actually see how much of that mass or how much of, sorry, of the atrium that mass is consuming. And you can make measurements off of this as well. Also new to Echo is this concept of virtual reality, and I will admit I have no experience with this. I was lucky enough to get this slide from Roberto Lang, who lent it to me, but I think it makes a point of where Echo is going and how it might be helpful in the evaluation of masses. This is a 3D data set of a valve, but it very well could be a 3D data set of a tumor or a mass. And once you have that 3D data set, you can come over to your workstation and you can put on these snazzy glasses and work with software that will allow you to go in and manipulate the data set, and really almost as if you are traveling through that data set. And although I have not seen this applied to cardiac masses, I can imagine that this could be helpful, say in a conversation with a surgeon who's preparing to do a complex resection. And before I move on from Echo, I'm going to talk a little bit about the use of ultrasound enhancing agents, what we used to call echo contrast, to characterize perfusion. I will say that this is an off-label indication for the use of ultrasound enhancing agents. In this example, we see a patient has a very large mass infiltrating the right atrium and abutting the right ventricle on the apical 4 and the subcostal views. Over here, we infuse the ultrasound enhancing agent and deliver a high mechanical index pulse. And when we do that, it suppresses the signal coming from the ultrasound enhancing agent universally, but then you'll see sort of this uptake of the contrast right around the mass. So you see it goes dark, and then there's this ring of the mass, of perfusion, if you will, around the mass, and it spares the center. And so this heterogeneity of uptake of the contrast after the flash tells us that this is sort of partially vascularized mass, and so most likely a tumor with a necrotic core. And this turned out to be an angiosarcoma. The right atrial location and the large size were also supportive of that diagnosis. But often we really kind of need to move beyond echo in order to be able to understand some of the tissue characteristics of the mass that we're examining. And I had a conversation with my MRI colleague Amit Patel and about his process when he's using MRI to evaluate a mass. And so, what is your process? He said, well, first I just have to find it. And so that's his first question: where's the mass? And he uses a series of cine images acquired from the neck down to the diaphragmatic level to identify where the mass is. And then once he identifies the location of the mass, then he'll image in whatever plane is suitable to be able to look at its T1 and T2 weighted properties. Now, I understand that malignant tissue, yes.
Sorry to interrupt your flow there. This is Dan.
Hi, Dan.
Thank you for this really amazing presentation so far. Do you guys actually use echo contrast in evaluation of mass, like you just showed?
Yeah, so we do if there's some concern about whether a mass is a tumor or a thrombus. So we wouldn't use it in a situation like I just showed you. I mean, we did because I have that example, but it's not really useful in that situation where there's an obvious, there's something obviously wrong here, right? There's a tumor and we don't really need the contrast so much to be able to tell us that. But in situations where we may have a background of somebody who has cancer and we see something that we're unsure is a tumor or a thrombus, that's where I think it could be useful, because a thrombus won't take up contrast. It doesn't take it up at baseline. If you perfuse it, it doesn't do anything. And so I think it can be useful in that situation.
So the perfusion nature of it, I guess that's my question. With echo, do you feel like you can tell?
I think if the mass is in the near field, yeah, I think you can. I think it's, I think it's worth a try, I should say. We've certainly had some success with it. We published on this back in 2004, our series, and at that time we were actually using the video intensity curves to actually measure, as opposed to just qualitatively estimating the signal intensity coming from the various parts of the mass relative to the myocardium, and correlated that with the anatomy at pathology and then the vascularity, and it did correlate.
Okay. No, I mean, I think, obviously that's some technology that you've gotten used to handling. I think for people who may not use it as frequently, it's really hard to tell, and at least in my view.
Yeah, yeah, it can be, and not all masses are, are suitable for this. So if it's really far afield, I think it becomes a little bit more murky. But if it's in the near field, I think that's probably the best, the best scenario for perfusion imaging.
Great. Well, thank you for answering that.
Oh, sure. Yeah. And I mean, I'll get to it here in MRI. I mean, I feel like we have more sophisticated ways to evaluate perfusion now, but, as I said, I think echo's our first stop. And so if we can extract as much information as possible, I think it's worth a shot.
Great.
Yeah. Sure. Thanks for the question. So malignant tissue, I understand has a higher water content, but more intracellular fluid and more extracellular interstitial fluid. And that higher water content leads to longer T1 and T2 relaxation times. And that actually allows for more contrast between malignant tissue and normal tissue. And so that's how T1 and T2 weighted imaging at this phase, where you're trying to locate the mass, can really distinguish the borders of the tissue. And after that, the next question is, all right, I've identified the mass and its borders. What are its tissue properties? And again, that's where they use sort of the signature or the fingerprint, if you will, of tumor types to really kind of narrow down the differential diagnosis. And in that tissue characterization, we also include fat saturation, which is helpful if the mass is a fatty tumor, so like a lipoma, for instance, or for pseudotumors that are heavily comprised of fat, like lipomatous hypertrophy of the intratracheal septum, for instance. Also included in the tissue characterization is the presence or absence of LGE. So the absence of LGE would suggest an avascular structure, most commonly a thrombus. And that brings us over to the next question about perfusion. And so we want to evaluate perfusion, this first pass perfusion, as well as late gadolinium enhancement. It will tell us both the magnitude or the strength, if you will, of the gadolinium enhancement. Strong LGE would suggest a highly vascular structure, as well as the heterogeneity that we may appreciate even on the first pass perfusion. I don't know if you guys can see all across my slides, but and then the next question is whether it's tethered, and that's where myocardial tagging comes into play. And this really, I feel like, is a good technique when you have a pericardial mass and you're trying to determine whether it's infiltrating into the myocardium. There in the literature have been some descriptions of features that are more suggestive of malignant origin on MRI, and so the right atrial location, involvement of more than one cardiac chamber, pretty large size, a broad base of attachment, certainly extension into the mediastinum or great vessels, and a hemorrhagic pericardial effusion. Those are all more sinister signs, and it can be discerned with cine T1 and T2 imaging. And then, of course, the presence and the strength of LG, as I mentioned, as well as its heterogeneity, is evident on gadolinium. And I mentioned just a minute ago about a sort of an MRI fingerprint or a signature that tumors tend to have. And this is a table. There are many tables like this and a lot of review articles. And we often reach for something like this if we're confronted with a mass to try to, narrow down the differential diagnosis. But I'm not an MRI reader, but my MRI colleagues say, well, this is very handy. But we also have to acknowledge that masses don't always respect these rules that, this box that we put them in. So we have to bear that in mind.
I think, Jean, that, to your comment there, I think, of course, an echo-centric person is going to say, echo is going to get us 95%, 98% there. An MRI-centric person is going to say an MRI will get us 98 or 100% there, depending on how MRI centric they are. But the truth is that it's the context of the mass and the patient story.
Right, absolutely.
So if you have, it's the rest of the story. The image is, can be very good, but in the context of what's happening with the patient is what's going to be very predictive of what that mass is. So I think that anyone can say, yeah, echo is going to do it, MRI is going to do it, whatever. There is no image, as you said. It's kind of the imaging train. There is no single image that's going to get every question answered. It's
couldn't agree with you more.
A whole picture.
Yep, I couldn't agree with you more. And I'm trying to focus this conversation that we're having in the next hour on tumors and in patients with cancer. And often, we already know they have cancer, right? So it's not always so mysterious in this patient population what's happening. But my goal here is to these patients do get imaged, and my goal is to help the end user of some of this imaging, this imaging test to really be able to extract a lot of information from those reports and understand the kind of the terminology and how some of these imaging sequences, to say in MRI, are particularly helpful in differentiating and how they might be different from echo or PET or CT. So bearing in that in mind and sort of on the background of the previous slide where we talked about all these different MRI features, I'm going to talk about, I'm going to show just a couple of examples, again, fairly out of context to your point, Dan. Patients who came to the lab and had a mass of some sort and then went on to have MRI and sort of some of the MRI tissue features. So this is a 31-year-old with recurrent low-grade fibromyxoid sarcoma who was pregnant and then ended up getting an echo, for her pregnancy. And as you can see, there's a well-circumscribed mass in the anterior septum that you can see on several of these views. And then on MRI with a T1 weighted imaging, you can see some thickening and some irregularity of the septum, but it's not really jumping out at you that something is really otherwise amiss here. T2 weighted imaging shows this sort of brightness within this region of interest, and you start to think, okay, well, tumors are bright, many tumors are bright on T2, so this is probably a tumor. And then you come over here to late gadolinium enhancement, and the MRI reader in this situation said, wow, this isn't really an enhancing lesion. And if it were a tumor, I would expect it to be an enhancing lesion. And so that was a little bit mysterious. And then he went back to the echo because he thought, maybe I'm dealing with a cyst. Maybe this is some sort of weird cystic structure. But going back to the echo and seeing this mass, this is not the echo feature of a cyst. And so he concluded that this was probably a tumor. This patient had been treated, and this was probably, an area of necrosis that was left over. And I think this case sort of nicely demonstrates that for multimodality imagers, they often float from one imaging technique to the other to kind of refine their interpretation. This is a 45-year-old with metastatic tenosynovial giant cell tumor with sarcomadoid features. And again, peristernal lung, similar to our last case, just sort of this, kind of odd shape to the interventricular septum. And then I don't know if you guys can see these arrows, but on the short axis, you can see this would be the RV insertion point onto the septum. And then you can see that there's this, the shape that really sort of doesn't obey tissue boundaries. And then also down here near this inferolateral wall, you can also see that there's a mass here as well. On the apical four-chamber view, you almost see like an interruption between the epicardium and the annulus. And so this seems like this is a mass that's maybe coming in from outside, and how much it's infiltrating the myocardium is uncertain. 3D wasn't extremely helpful here, but I do think that it was able to show you some, a difference in contour across the interventricular septum. So I'm using this example as really kind of a way to highlight the idea or the concept of tagging. So you can see the staining image here looking very much like the echo image. With tagging, you have these diamonds, or you put this sort of grid over the image, right? And you have these diamonds in this area outside the heart that's very fixed, that's not moving. And you can see those diamonds just kind of stay the same shape. They don't really distort at all. Whereas in areas that, like the myocardium, that contract and expand, you'll see distortion of those diamonds during the cardiac cycle. And then down here where the mass is, you see some distortion where the myocardium is, but where this mass appears to be infiltrating, it really seems, again, not to respect boundaries, and these diamonds don't really distort very much. So it just sort of implies that this is a very tethered and kind of matted tumor. And then we have a case of a 37-year-old with appendiceal cancer with peritoneal mets, and she had a history of recurrent PEs. And on echo, you can see sort of this fleshy looking echo density here, but then pops in this very hyper intense or echo bright structure here. You can see the two masses in these other images as well. If you're imaging posteriorly, you see this lighter thrombusy looking thing, and then if you're imaging more anteriorly, you see this more bright mobile echo density. And so that was curious to us, because we wouldn't have expected, can't say I have a lot of experience with appendiceal cancer, but I wouldn't have expected that to metastasize to the heart. But these are very different echo textures here, and you can appreciate that as well on the TE. So the sort of brighter one that looks more like a clot, and then this one here, which is sorry, the less bright, and then this one here, which is more bright. The one that's sort of more fleshy appearing seems to be associated with the catheter, and we think that that was caused by abrasion of the endothelial surface of the right atrium. And then this one, which is brighter, can't really tell where it's coming from, and it doesn't seem to be, at least in this image, associated with the catheter. And this is the transillumination of that. So this patient went on for MRI, and I hope you can see this. On the T1 weighted images, there's sort of these two structures. They kind of look fairly uniform in their T1 properties. With the T2, they also seem fairly uniform, maybe a little bit, this one a little bit brighter. And then they gave gadolinium, and I guess when you infuse gadolinium, I'm speaking as a non-MRI person. So when you infuse gadolinium, you can, the idea is to wait until the myocardium appears nulled, and then that's when you start to acquire your gadolinium enhancement images. But if you acquire during the earlier part of that infusion, before the myocardium is nulled, and you see a mass that's bright with this short inversion time, and then dark on the longer inversion time, then that apparently has very high sensitivity and specificity for thrombus. You see Lauren Baldassari, who's an MRI expert, is panelist here. And Lauren, am I on the right track there?
Hey, Jeannie. Yeah, absolutely. Can you hear me okay?
I can, thank you.
Sorry, I'm in the MRI suite here, but yeah, no, I mean, you've done an awesome job of laying out the MRI stuff. I mean, but that is true. I mean, so basically, when we do late gadolinium enhancement, like you said, we normally time what's called the inversion time. It's a parameter of the scan to when the myocardium is fully uniform, dark, and nulled, like you were saying. And then when we do dedicated thrombus imaging, Then we do this long inversion time, which you can see on your image, the myocardium is actually a little bit gray, so it's not nulled. And then areas that didn't take up any contrast, like a thrombus, would be very dark on that. And so that's really helpful, to distinguish thrombus in general. It's super helpful if you have like a layering thrombus where you have myocardium right next to layering thrombus to give two different, tissue characterization of structures that are immediately adjacent to each other. And like you said, I mean, really ultimately, like cardiac MR has been the gold standard for assessment of like LV thrombus. And it's increased sensitivity compared to, echo, even with echo contrast, and increased sensitivity compared to even, non-contrast MRI as well. So it's not just about looking at the structure and finding the thrombus, but really about the tissue characterization. And I actually think, you're making great points, and I don't want to talk too long, but I think one of the areas, obviously, as you've mentioned, helpful to characterize the tumor, but I think even specifically in cardio-oncology patients, and patients where they already may have even known metastatic cancer, really that question of the thrombus, either thrombus versus tumor, or is there a thrombus component on top of a tumor, is actually something that does change management, in patients. So that's a pretty common, clinical scenario where we'll do a cardiac MR.
Super, thank you for that. Yeah, so in the end, with the late gadolinium enhancement, there wasn't enhancement. So the conclusion was that these were both two thrombi, but probably just of different age and chronicity.
Gene, to kind of pull all that together, so then what was done in that patient?
So this patient had a line, and they wanted to remove the line, and they were afraid with this, the more brighter one that was, flipping around in the atrium. They were a little bit concerned about removing that. And she had a history of recurrent P's. They thought that she didn't have a lot of reserve, so they angiovacked it. And the pathology did confirm that it was thrombus.
Yeah, awesome. Yeah, we did a ICOS webinar just under a month ago, where we talked about extraction of thrombi through angiovac and other tools. And this is a perfect example of where that really could matter greatly. And also, even though the image was, sorry about that, even though the image was very convincing about, that it was likely a thrombus, the fact that you did an angiovac and then you look at the pathology and confirm that in fact it was a thrombus is sort of a critical element.
Agreed. Yeah. So now, I've shown you some isolated cases just to make a few points from in terms of imaging and some of the terminology.
Sorry to interrupt. I think there was another question. Deborah.
Okay.
Deborah had a question. Deborah Sunloff.
Yeah, thank you. And this is wonderful. So thanks for doing this. My name's Deb Sunloff. I'm a cardio-oncologist, the director of our program in Bethlehem, Pennsylvania, Lehigh Valley Hospital and Health Network. But I had an interesting case, a young lady who had breast cancer and was, to make a long story short, on several different chemo agents, had a port placed, was found to have a 2.2 by 2.3 centimeter mass in her right atrium associated with the port. And she was sent to me because of that mass. We did a PET scan, and so that mass didn't light up. We were assuming it was thrombus. Put her on apixaban for 2 months, repeated the CAT scan. The mass was still there. We didn't want to pull the port for risk of it embolizing. So we switched her to warfarin, and then within a month, the mass was gone. So I was wondering if you had any insight into why DOACs wouldn't necessarily be as effective in that type of situation compared to warfarin.
I don't, except, you just have, you're just making the Just extrapolating what we know, the amount of data that we have about LV thrombi. Our practice here is if we see somebody with an LV clot, we do use warfarin just because we have more data on that than DOAC, and that's in all comers, not necessarily cancer patients. And so, I guess you could apply the same for line-associated thrombi, right? I guess in your case, the question is, was it the difference between the DOAC and the warfarin, or was it the duration of therapy that made the difference? I'm not sure.
I think it was a difference in therapy. I mean, but I totally agree with you. When we see left apical thrombus, we tend to use, we use warfarin, but there have been a couple incidents where my patients are like, I don't want to take warfarin, so I put them on a DOAC and watch them very closely and let them know we're using it off label.
Yeah.
But you would think that if we use it for left atrial appendage thrombus, it would work for right atrial thrombus. But I just throw that question out there. So thank you for your insight.
Yeah.
Yeah, Deb, I would just add to what you guys said. I mean, I agree generally with all the things that were said, but if you're not gonna, there's no randomized study that, at least that I'm aware of, in any way, shape, or form that says Coumadin versus a DOAC versus low molecular weight heparin, which one is better in the context of an left atrial or LV thrombus. But you can extrapolate from cancer trials that if you compare Lovenox to Coumadin, Lovenox would be far superior in terms of recurrent thrombus. So instead of a DOAC in that case that you brought up, I would say that the strongest data out there would actually be for low molecular weight heparin.
Yeah, I actually offered her that, but she faints at the sight of needles, so she didn't. She felt that wouldn't be a good choice for her.
Oh, okay.
So-
Well,
so
I'm gonna.
We didn't mean to sidetrack you, Jean.
No, it's all good. It's all good. So I showed you a few isolated examples in the previous few slides of just masses, just to kind of prove some imaging concepts. But as Dan said, we always look at this, we use imaging within the context of a case, and we helps us manage a case or to try to understand what's happening with the patient. So I have 4 cases for you. I'm not sure I'll get through all of them, but I'm just gonna start with the first one, and the patient with a new cardiovascular symptom, but with a known malignancy, right? This is a 33-year-old who had initially presented with a supraclavicular mass, and that led to a CT showing a very large mediastinal mass, which I'll show you, with HCG levels that are elevated in alpha-fetoprotein. It's like 5, I think it was. It was diagnosed with extragonadal metastatic seminoma, and he received bleomycin, etoposide, and cisplatin. And his initial presentation, he was coughing a lot. And then as he got treated, that improved, but now it was recurrent. And so much so that when he came to my clinic, he had presented having had post-tussive syncope resulting in a motor vehicle accident. So this is his pre-chemo CT scan. And you can see this just enormous mass that really encases the central venous supply. And this seems to want to travel to the SVC and the right atrium as well. Then after treatment, this mass is much smaller. The image itself is much smaller, but the mass is smaller. And then this is, the SVC RA junction. You can see something sort of dangling in this area. And you don't really see much more of the SVC, which is either infiltrated by this mass or there's a tissue plane somewhere in here and there's something inside the SVC as well. Can't really discern that from the CT. But on a slice that's further down, closer to the heart, an axial slice, we see this is SVC, and then this is some structure within it, and then separate from that, you seem to have this large mass. Again, can't really see if this mass respects the tissue planes or not. So our question was, what is this an invasive mass? And then also, was this thing that we're seeing in the SVC, is that tumor or is that thrombus? And so on his T1 images, this is just sort of a homogeneous kind of gray schmutz, if you will. This mass that we saw on CT with the SVC, and T2 didn't really help us too much. I mean, it's a little bit bright, but it's not really striking. And when we look at that area near the SVC early, and then early after gadolinium, this is a little bit lower down toward the heart, and this is higher up. We can see that initially it doesn't really look like it's obstructing venous inflow, but as you come more superior, it does actually look like it's consuming most of the SVC. And even with MRI, I think it's really hard to tell. And maybe Lauren has something to say about this. It's really kind of hard to tell. If the tissue plane is, if the IVC is truly separate from this mass that seems to be encasing it. On the late gadolinium enhancement, it doesn't enhance. So we thought, okay, this is most likely thrombus, but still didn't have a great explanation for what this other stuff was and whether it was, an active malignancy. Turns out the oncologist had ordered a PET scan, and we had ordered an MRI, but our MRI got done first. And so this is the PET scan. So, there's really nothing striking in the area where this mass is in the SVC. And, I talked to the oncologist and I said, well, what is the mass then? And he said, with these germ cell tumors, after they're treated, they leave behind this like fibrous mat, and which is incredibly adherent to its surrounding structures. So we did try this patient on some anticoagulation, and it was DOAC, and we didn't, see any improvement on serial imaging. So his symptoms were impressive. So we thought, well, it almost doesn't matter whether this is a tumor, residual of a tumor, or whether it's a thrombus, because he has obstructive symptoms and he needs surgery. This is his intra-op TE, and I'm just showing these images to make the point that, I'd said earlier that sometimes TE can be limited because of its ability to be able to visualize structures, and this is an example of that, where we can see the portion of this mass that's coming into the SVC, from the SVC into the right atrium, and we can see it on the short axis as well, but we really can't see the area that's obstructed further up, so more superiorly. And the 3D is not particularly helpful here, because bottom line is, if you don't have good 2D imaging, you're not going to have good 3D imaging. So at surgery, the surgeon incised the right atrium and looked up toward the SVC and sees this sort of, I wouldn't call it fungating, but fairly large mass. And then when he resected that, he was able to see some restoration of flow, or return of flow into the SVC. But on his scans, most of his head, the venous supply, a return coming from his head was coming from the left IJ, and you just thought that was going to be inadequate. So they did a nominate vein to right atrial appendage Gore-Tex graft to, kind of create more or less a new SVC. Patient did well, his symptoms resolved. This turned out to be, again, like a fibrous mass. So there was no evidence of tumor within that. It was not clot. Next case, a patient with new cardiovascular.
Jean, on that case, really fascinating case. Great presentation. On the CT, were they able to do any kind of, try to show any contrast of the lumen?
So there was the one where you could see on the short axis that there was contrast around this area. But so we felt like higher up, we couldn't see any contrast around that mass. Lower down, closer to the entrance of the SVC with the right atrium, we could see some separation between the mass and the walls. But that's kind of it.
So, yeah, I think that would have been the significant determination whether or not you could have done a percutaneous stenting of the SVC, for example. If you saw a clear lumen, you might have been able to do it percutaneously, but by going to surgery, you made obviously a new clear channel, which I'm sure is great for the patient.
Mm-hmm. So I'm going to move on to the next case, which is a patient with a new cardiovascular symptom, but no known cancer history, 49. Went to the outside hospital with unresolving quote unquote URI symptoms, but was noted to have shortness of breath and new lower extremity edema. All this, I suppose, was unexplained. It resulted in a PE protocol CT, which showed a large pericardial effusion. The effusion was tapped and about 700 cc's of fluid was removed, but then it quickly recurred. So the patient was sent to CT surgery for a window. And at the time that the window was made, the pericardial sac was not decompressing as expected. So the surgeon did an open exploration and found a mass along the lateral LV border that was adherent to the epicardium. The path from that biopsy was consistent with synovial cell sarcoma. And sensing that this patient was going to need a larger resection, the patient was sent for additional imaging. And the questions, at that time were, is there extension of this mass into the myocardium? And by the way, what's the ejection fraction? Because the patient's probably going to be treated with high dose anthracycline chemotherapy regardless. So this is the cine MRI. This is the still frame of that. This is the mass. And on the cine, you can see this mass is really, seems to be encasing the left ventricle and kind of creeping up onto the left atrium. This is just one frame of the cine, but in the stack. But if I were to show you the whole stack, you'd see that this mass actually comes up to the level of the pulmonary artery. So it's pretty extensive. And this is a T2 stir. Sorry, super sensitive mouse here. This is the T2 stir image, and you can see that this mass, again, you can see sort of the size of it is pretty massive, and it's very bright on T2 stir imaging, which tumors tend to be. And then even around the pericardium, this is also very bright. So, there's probably some associated inflammation. And here's the first pass perfusion, where you can see that this is a vascularized mass. The views change, so I'm going to let this play because this is the image that we started with, and then we'll kind of change over. You can see the mass over here up at the level of the pulmonary artery, and then here on a short axis slice, you can see that it really kind of circles the heart. So definitely perfused, consistent with the pathology of being a cancer. See if I can get to the next one. And on LGE, you can see that it does enhance, but it's pretty heterogeneous. And so this might be area of a tumor necrosis. I don't think it's fluid. Again, getting back to some of our earlier slides where we talked about the strength of late gadolinium enhancement and its heterogeneity, really kind of argue more for a malignant process, which we already knew, but the images were supportive of that. And so I wanted to ask Lauren, or anyone else on the call, this patient was going to go for a resection, and we did not, and our surgeon did not request any kind of anatomy, any evaluation of the coronary anatomy. And I was curious, would you have tried to do cardiac MRI? Would you have tried to outline the relationship of the mass to the coronaries, like specifically of left circumflex in this case, with MRI as a one-stop shop? Or do you really feel like that's maybe one of the bigger limitations of MRI, and maybe, go to CT for that?
Yeah, I mean, that's a great question. I mean, you could definitely do like a dedicated coronary sequence, which usually is like a 3D whole heart, and it's like respiratory navigated. So the patient just kind of like breathes regular and shallow over the course of like a few minutes to kind of get this high spatial resolution 3D image where you can usually delineate nicely the coronaries. I think if it's like the coronary is like fully compressed in that area, you probably would just see that you lose sight of the coronary at that point. You're probably not going to be able to follow it through within the mass, but you could see at the proximal point. I think the other, high value imaging modality at that point would be a coronary CTA. I mean, obviously, unless the patient has a contraindication or some severe renal disease or something that you're avoiding it, because then, you've got a dedicated study specifically for the coronaries. The cardiac MRI is great to look for like anomalous coronaries and to look at sort of the origins and often the course. But like to look at more subtle things like areas of stenosis, it can be done in a dedicated sequence. People do dedicated coronary MRA, but it's less frequently done, you know, to look at like areas of stenoses, and more frequently done to look for anomalous coronaries. And usually if we're wanting to look at, you know, specifics of percent plaque stenosis, usually we go to coronary, you know, CTA, knowing that it can be done with MRI, but it's just not clinically as frequently done. It's just easier to do, quite frankly, with a coronary CTA when you're looking for percent stenosis and things like that. So, and then it's really indicated, and especially patients who are, you know, lower, you know, to intermediate cardiovascular risk going for cardiac surgery. It's like a great, right, non-invasive test, especially in cancer patients if you're trying to avoid more invasive procedures, to just do a coronary to look at it before. Yeah.
Thank you. Yeah, and in fact, as I was preparing the talk, I thought, oh, you know, I'll have a couple slides on the use of cardiac CT, but you know, really, it doesn't seem like this is, you know, the cardiac CT is utilized often, I should say, for the evaluation of cardiac masses. But where it does seem to be good is if you're, you know, if you're detecting calcium within a mass, or you're trying to determine if something is just calcium and not something else. And good for pre-op planning, as Lauren mentioned. You know, there's volume and cinematic rendering that can, this is an example of a sarcoma up here that I'm showing you, where you can see in the final image D, this is, you know, with cinematic rendering, how you get almost a photorealistic image. You know, it has fast acquisition time, which I think Lauren was getting at. It has really good spatial resolution. It lacks some of the temporal and the tissue characterization that we tend to see with MRI, and so it doesn't have those advantages. Getting back to our patient, at surgery, this mass was resected. It was huge. It was 20 centimeters. I think that's huge. And the cast, you know, it really, the surgeon said it extended from the main PA, wrapped around the LA and the LV to the apex. And I feel like this mass is like a cast of the images that we had on MRI. So there was good correlation there, and then consistent, you know, again, with sarcoma.
Jeannie, can I ask a question? It's Jennifer. It's been a great case. Going back to the question, you know, often the surgeons that are doing the resection at least at Memorial are thoracic surgeons. They're not cardiothoracic. They don't have a cardiopulmonary bypass in the OR. So the question that's often asked by the imagers is that, is the mass involving the myocardium? Obviously, there's some cases that are very obvious, but there are other cases where, you know, it's pericardial base and they want to try to strip that, but they're asking us to be as certain as possible whether there's myocardial involvement. So do you feel that MRI or CT, or maybe Lauren can also speak on this, how accurate can we tell the surgeons that no, there is definitely not myocardial involvement?
Well, in the case that I just presented, it did seem on the MRI that this mass was not infiltrating, and we could see the tissue planes pretty well. So we felt pretty confident about that. But I don't know, Lauren, what you would say in terms of, you know, I don't know if there's any data on sort of sensitivity, specificity type of thing, or what your general experience is with that.
Yeah, I mean, I think in general, it's kind of like you showed. I mean, you know, in that case, I think you did see clearly that there were tissue planes, and, you know, implied, like you showed before, like the tagging sequences where we can really see if things are like adjacent to each other and like sliding against each other where there's a tissue plane, or if they're really coming together, matted, you know, the myocardium's contracting and pulling, you know, the mass kind of with it. And then I think if for whatever reason it's not clear on the cardiac MR, the cardiac CT, I mean, as you already highlighted, has a lot of value for evaluation of cardiac masses. Like you said, it's not necessarily first line, but it is good in distinguishing certain masses, especially calcium, which it's better at than MRI. And then, you know, if patient can't tolerate an MRI, and then, you know, there's, if the patient couldn't hold their breath on some of the images for MRI, then a CT, like you said, it's quick, it's fast, you get the whole 3D data set at one time, and you can manipulate the image, any way you want. Whereas opposed to MRI, each of those sequences is usually like a breath hold, and they're in the scanner for a longer time. So I think like often we can tell in every single case, there maybe not, there might be a question, but usually if we do the right dedicated sequences, and as you highlighted, like Amit Patel said, the first thing is you got to localize the tumor. Once you've localized it, usually in 2 cross-sectional planes, you apply all of those different sequences in those specific planes. So if you've got targeted imaging, usually you can get a pretty good sense there.
Yeah, but Jennifer, I would add that your question is quite unique. I wouldn't say unique in the world, because when I was at MD Anderson, I would have the exact same question asked of me, which came from the thoracic surgeons.
Right.
But how I would answer that in general is that definitely based on imaging alone, you can be pretty confident, but I wouldn't say I'm not 100% certain under any circumstance.
That's right.
And if you are going to take this patient for potentially a curative surgery, you better get all the people that you need to, have the best outcome from the surgery. So in that setting, I would say you better make plans that you're going to need to go on bypass. And if you need to transfer to a different institution that has that capacity, then I would do it.
Absolutely. I think you bring up a really good point, that even though for the most part we have a great advanced multimodality imaging, but we all have to be humble as imagers that ultimately, there are cases where, we can't absolutely make the diagnosis.
Yeah, I would completely agree with that. And we have the luxury where these are going to, cardiothoracic surgeons here. So we kind of always have that backup. But you're right, especially with a pericardial tumor. I mean, that did look like, there was a plane, but in general, I mean, there could be one little spot that's hooked on, and that could tear something when there's, so obviously, yeah, it's high risk. Agree.
Yeah, thanks for bringing that up. That's a good discussion. We're kind of short on time. I'm going to race through this one because I want to get to the 4th case. So this is an asymptomatic patient, incidental finding on echo, known cancer, 67 with pleural mesothelioma. Just for brevity, he's treated with a bunch of chemo. He had an MRI that was fairly unrevealing because of complications from his therapy, and then started on more chemo and planned to have a CAR-T out of state, and an echo was requested for that. On the echo, you can see again, it's sort of an odd shape to the apical septum here on the apical views, the 4 and the 2, and even a little bit on the 3-chamber view. And overall, wall motion seems to be best preserved at the base and the mid-level, maybe a little bit less robust at the apex. The reader read this as possible thrombus, but acknowledged that, the myocardium is taking up this echo contrast, and this area that's abnormal also appears to be taking up a little bit of contrast. So, again, to Dan's point, in a clinical context, you have to put tumor in the differential diagnosis. And these images are admittedly darker, but this was 14 months prior, and you really just don't see that difference in shape down at the apex. So the patient went on for MRI, and this is an example of the use of cine here in the 4 and the 2. Again, reproduces the same findings that we had on the echo in terms of the morphology. And then this area, at least partially, takes up gadolinium. So there's LGE in this area. And so this was read as tumor and not thrombus, and that had a significant impact on what was being offered. And so the patient did not go to CAR-T. He had other plans for him. This was a particularly helpful case. And then looking at his PET scan that was being done, this is, I'm just going to preface this by, this was not a PET scan that was done with proper fasting or a low carb diet. And so generally we should really reserve a significant amount of caution when we're looking at any PET images that weren't, of the heart, where there wasn't proper prep. That said, there's a a light bulb here in the apex in an exact location as the other findings here on the MRI. And so we felt pretty confident that all of this was concordant with tumor. Last case, patient with, cardiac arrest, cardiac arrest and no known cancer. This is a 76-year-old. He presented with low-grade fever, dyspnea, and fatigue to an outside hospital and was found to have a large pericardial effusion. It was drained. Cytology was pending at discharge, and then a few days later came back with large atypical B cells concerning 4 B-cell lymphoma. While she was in that hospital, she got the first dose of her COVID vaccine, and no, not yet. She got her first dose of COVID vaccine, and that can cause lymphadenopathy. So the oncology team wanted to defer her CT for a few more days, at least until she could get the morning of her COVID, her second COVID vaccine dose, thinking that any lymphadenopathy from that would have attenuated by that time or resolved. But meanwhile, she represented to a local cardiologist with fatigue and dyspnea. And the thought was that she would have probably a recurrent pericardial effusion, but instead she was in complete heart block. She was sent to our ER, verified complete heart block, and then promptly had a VT-VF arrest in the ER. She was sent to cath where she had no obstructive coronary disease. A transvenous pacemaker was placed, and then ultimately permanent pacemaker was placed shortly thereafter. But then the question was, what's happened here? Like, what happened to the patient? So the hem-onc folks were appropriately concerned about the B cells in the effusion, and they did a CT of the chest, abdomen, pelvis, which was negative for lymphadenopathy, which was a little bit odd. There was some mention of some fullness and around the aortic arch, and they said neoplasm could be part of that differential. But I think that the picture that the oncologists were expecting on the CT with lots of bulky lymphadenopathy was not the case. And then EP said, well, if you're not seeing lymphadenopathy, then I guess we should be considering sarcoid in the differential diagnosis. And normally they would reach for MRI, but the patient had a brand new pacemaker, so they could not do an MRI. And so they decided on doing a PET, which seemed to be a good answer for everybody. And on the PET scan, you can see the uptake here this is the septum in the lateral wall of the LV, septum, the RV, that area in the ascending aorta around the arch that was mentioned on the CT scan. And the SUV max standardized uptake value was pretty high in these areas. And the report, I have to say, was the scan was helpful, but the report was not so helpful because it was like read as possible sarcoid, possible lymphoma, maybe renal cell carcinoma because of these 2 right renal lesions. Like something was going on. It showed us that there was something going on in the heart, for instance, but really didn't help narrow the differential diagnosis, unfortunately. The most accessible place for a biopsy was the stomach. So the patient had an EGD, and the pathology on that showed diffuse large B-cell lymphoma. And so at that point, they thought that was a pretty unifying diagnosis. And that's, we use PET a lot for, or oncologists use it a lot for, for malignancy and to look for tumor involvement in other organs. There's really only a few case studies that apply it to the evaluation of cardiac tumors. And they're very small, like 20, 30 patients. And another thing is that, you really have to be on a proper diet to suppress the myocardial glucose metabolism. And this is an example of the diet over here on the right, which, basically is just eat meat and don't eat anything else. So definitely no carbs. And so I found this probably the most recent, and I think the largest series of looking at PET or using PET for cardiac tumors. They had only 38 patients. They broke them into 3 groups, and you can see that the SUV max increases as you go from benign tumors out to malignant and then metastatic. And then this tumor to background ratio is the SUV max of the tumor relative to the SUV max of the blood pool. So a value over 1 sort of implies that the tumor is more vascular than the than the blood pool, or is brighter than the blood pool, and that would be suspicious for a tumor. And you can see that this value also, is sort of marginally abnormal in benign tumors, but becomes quite abnormal in malignant and metastatic tumors. And then when they used cut points of 3.44 for SUV max and 1.55 for the tumor to background ratio, they found that this had a high sensitivity and specificity for predicting malignancy, with good area under the curve. And so, I thought, well, I wonder if we should be looking at the heart a little bit more, or maybe if we had something in the heart, maybe we could use PET, because that's kind of a nice tool. But the radiation exposure on this PET CT scan, for instance, I mean, this was a whole body scan that's being done. It was like 12 to 17 millisieverts, which I don't think is so insignificant. Now, looking at the heart and just asking the person to take a cardiac, take the low carb diet and fast doesn't add to the radiation, but as a standalone procedure to evaluate cardiac masses, I think is probably, MRI and echo would certainly be safer from the exposure standpoint. So just wrapping up, because I think we're pretty much out of time, as to take home points. Most primary cardiac tumors are benign, and the malignant ones are often sarcomas, and secondary cardiac tumors are mainly METs. The location and clinical setting are big clues to try to differentiate a benign finding from a malignant finding, or a just a non-tumor mass from a tumor. Large, infiltrating, and perfused masses raise concern for malignancy, but we need to remember that not all masses in a patient with cancer or tumor. Echo and MRI tend to be the highest yield modalities. Cardiac CT might play a role for the identification of calcification or delineation of the relationship between a mass and surrounding vascular structures, helpful, for instance, in surgical planning, as we discussed. PET requires fasting and a low carb diet to be able to glean really much from the cardiac images. And as a standalone way of just looking at the heart, probably not favored, but it may play a role in the evaluation when MRI cannot be performed. So I'm going to stop there, and I'll take any other.
So, Jean, this was a treatise on the imaging and the evaluation of masses. So really fantastic, amazing. But I will say that just based on the cases you presented, we probably ought to have an entire webinar on PET, because if you go to your first case that you showed, the cardiac uptake on that PET image was really intense, and you didn't even talk about that, which is, you weren't looking for cancer in that case necessarily, but the PET image showed really intense homogeneous cardiac uptake. And so whether that's related to the way that the patient was prepared for the test, or whether it's something else, I've never really understood how to interpret that information.
Yeah, and you have to be, you really shouldn't be interpreting PET CTs, the cardiac portion of it, and cardiac structures, if a patient hasn't had proper fasting. Because there's papers on how you can have these false positive findings, and so you really have to properly prepare the patient. I mean, I think, oftentimes if we have a patient in clinic who has some chest pain that we think is atypical, and we see the patient has a CT, we'll scroll through the CT and look to see if they have any coronary calcium, right? And I have to say, I look at the PET just kind of out of curiosity, but it's out of curiosity. In this case, there's this big thing that's lighting up at the apex that happened to correlate with other things, other imaging modalities where we knew what was going on. But I wouldn't.
No, I think in this case the PET was helpful, but no, the very first image you showed, not before the cases, your very first PET image, look at the intensity of the cardiac uptake.
This one?
Yes.
Yeah, so this also was not done with prep, because the standard PET CT is not done. We don't ask the patients to do any specific diet for it, because the oncologists aren't really interested in looking at the heart, right? I mean, cardiac tumors are pretty rare, so their interest is outside of the heart. So if you were to, and we have seen, I've seen reports, and I've actually had an oncologist send me a report and say, what does this mean? And I'm thinking, I don't know that it means anything really.
You
So
know, the problem is that it may mean something. I just don't know what it is.
yeah, true. I mean, again, clinical context I think helps, and maybe correlation with other imaging. You know, that's already available. I don't say like if I saw this that I would track, you know, I'd start imaging the crap out of the patient. But if they had available imaging, then it might be nice to, you know, to look at that and put it into context.
Hello?
I mean,
Yeah, it looks like
Hello?
we'll take one question since we're over time. But yeah, Dr.
Okay.
Fioretti.
Thank you. I am Agnese Maria, Bari, Italy. Congratulations for this brilliant, rich speech. Recently, I have a case of a young lady with the breast cancer and the second metastatic pancreatic cancer. She was in full dose edoxaban for a previous DVT and EP, but she developed thrombosis in the right atrium despite full dose edoxaban. So somehow she was resistant and she had this extended and second thrombotic event. So how to manage this situation? Change DOAC or switch from edoxaban to low molecular weight heparin at therapeutic dose or supratherapeutic dose? Thank you.
This is, I think this is very similar to the question that we had earlier in the webinar. I think it was almost exactly like this, right? So I think the discussion at that time was, you know, that there's a lot of data on the use of Lovenox in the oncology population, and so that may be the way to go, you know, rather than the DOAC. But you know, I think we can't answer that question in a data-driven way, you know, at least with robust data, except for this, you know, issue that Dan mentioned, which is, you know, Lovenox has been demonstrated to be superior to even warfarin in this patient population.
Thank you so much, Dean. We'll let you off the hook. You did a fantastic, wonderful job, and we will definitely make sure this gets posted on our website. So thank you so much.
All right. Thanks, everybody. Have a good day.
Thank you very much. Congratulations.
Thank you so much.